So by way of introduction, emocha is a mobile health company based at the Johns Hopkins Medical Campus. We started off in 2008 by a team of clinician scientists at the Center for Clinical Global Health Education. And the core problem that these clinician scientists had back in 2008 before the kind of emergence of digital health or mobile health was pretty simple. They were working in rural Uganda and they needed a way to capture data in very remote locations in the field with a date and a timestamp that could be later transmitted to a web portal so somebody could review it in a larger metro area. So over time, they added ways to capture video asynchronously in the field, so without the need for internet, photo capture, linkage to care apps, medication reminders, patient communication, and before they knew it, they really built something that scaled far beyond the needs of their research study. And about 5 years ago, our CEO, Sebastian Sager, licensed that core technology and made emocha the company it is today, which is a company dedicated to using mobile technology to understand and improve medication adherence by empowering every patient to take every dose of their medication. And our vision is really contributing to a world where taking all your medication is a cultural norm and the deadly consequences of non-adherence are history. So I'm going to walk us through a case study of some work we did with CDC and Puerto Rico Department of Health partners on the island to really give that vision and mission a concrete meaning in a case study that we've since published. But many of you may be shocked that drugs don't work in patients who don't take them. It's really shocking. But if you notice, our Surgeon General said this back in the 80s, and here we are all these years later, and this is a still $300 billion problem. Patients still can't take their medication despite all these different solutions. And it's because people are trying to solve it as a one and done solution with a pill bottle or a reminder or an app. And it's really this fundamentally complex human behavior that has to be addressed holistically. And how we play in this space is really approaching it as this complex human behavior. So we are at the core a mobile health company. So we do have a patient-facing mobile application and a provider-facing web portal. But we really look at adherence in 4 big buckets, and we address each one a little differently. So the first piece of adherence that we target is this idea of human observation. So healthcare or not, people do better and perform better when somebody is watching them. So we think that that really has a positive impact when done appropriately for patients with complex behaviors. The next piece is really engagement and support. So we know that patients need different communication styles throughout different parts of their treatment, and that engagement and support needs to be tailored and delivered in a comprehensive manner to support the health behavior that you're interested in learning about. So this engagement and support tied to the patient's health journey has been really important for long-term behavior change. The third piece we really impact is regimen reconciliation. So a lot of times you have one piece of pharmacy information in an electronic medical record, another piece of information that the provider said, and a third piece of information that the patient heard or interpreted. And all 3 of those sources may not be combined. So we really use the technology as a vehicle to get everyone on the same page about what medication should be taken, when, and how. And the final piece of adherence that we really target is an incentive. So everybody needs either a financial or a social or some form of incentive to implement a change. So we really believe in tailoring this incentive to the patient's needs, again, throughout the course of their journey. And sometimes that is financial, so delivering an incentive based on taking medication. And a lot of times it's social, pairing somebody with a coach who's going to be with them throughout their medication journey, who's going to help them get through it no matter what. So those are the 4 pieces of adherence as we see it, and we impact each a little differently. I'll start with the core technology platform, which is a mobile app that patients use on their Android, their iPad, or their iPhone. So at a high level, patients download and open the emocha application. They log in with a username and a password or a PIN code or fingerprint based on their providers thinking they're a good candidate. They record a video of themselves taking medication. They receive encouraging comments and feedback. And they can follow along their progress in different dashboards of their health on the mobile app. All while, on the other end, a provider is reviewing and engaging the patient with their data throughout the course of their treatment. And how many of you are like, why would someone record themselves taking medication? Everyone probably, yeah, it's okay. So this is actually adapted from a tried and true public health practice called directly observed therapy. So does anyone know how that works in local public health departments? Really cool story. There are unsung public health superheroes, including in the city of Philadelphia, who every single day drive to a patient's home, deliver medication, watch them take medication, document symptoms and side effects, and comes back to the care team to deliver that information every single day for 6 to 24 months. As you can imagine, this is really challenging. But this was actually mandated by the CDC about 50 years ago in response to tuberculosis, which today is still the #1 infectious disease killer in the world. But 50 years ago, we had a core problem of clearly tuberculosis is contagious, and if a patient doesn't take their medication, they can infect others, and now you have a matter of public health concern. So the CDC said, we're funding all local health departments to create a tuberculosis control program, and we're funding them through a cooperative agreement that's separate from Medicaid, separate from all these different insurers, and we're going to fund a community health worker to literally deliver and watch medication be taken every single day until they hit 182 doses and complete their treatment. And they did that because they knew that if we can get patients to take their medication, we're not going to have an outbreak, patients are going to cure, so we're going to do whatever it takes to get it done. And right now, there's only about 9,000 cases of active tuberculosis in the US. So how many people just realize that tuberculosis is still a disease of great interest in the US? Exactly, right, yeah. And it's because you have all these unsung superheroes who are in these health departments who are going out and doing whatever it takes to get this patient to complete. And a lot of times these patients are lower resourced, they're new to the country, so about 86% of the population is foreign born. They don't speak English, they're new to this health system, and suddenly they have someone in a county car coming to their place of work every day to deliver medication. So it's helpful, but it's really stigmatizing, it's expensive, and certainly really difficult to do even in health departments, much less anywhere else for any other disease where adherence could be important. So what we did is really immersed ourselves in local health departments, both domestically and abroad, to understand this process and the elements of it that work really well, the elements of it that can be digitized to create what you just saw now, which is video directly observed therapy, or you'll hear me say video DOT for short a lot throughout the course of this presentation. So with that, I'm going to walk through a case study on how we deployed that app in the Puerto Rico Department of Health for their tuberculosis program. So we're very fortunate to work with about 50 different state and local health departments, domestically and abroad, using the platform in just everyday clinical care. But this study is really interesting for a number of reasons. One, on a personal note, I found out about a tuberculosis outbreak while on vacation in Puerto Rico. Second is my father, who was actually born and raised in Utuado, which is a city in the kind of center-ish of the island. So I have some personal roots here. And three, this was in December 2016, when there was the height of the Zika crisis. As you can imagine, a lot of resources were going in there. There were a lot of fiscal and budgetary issues around financing health on the island. And we had a tuberculosis outbreak in a home of cognitively impaired males when we had a staffing shortage without having that person who's able to deliver medications and watch them and support a patient during this critically important time. And here we have on the top of a small mountain in the middle of an island, a home of 17 males who all needed treatment, where people had died of tuberculosis in Puerto Rico, in the course of our lifetime. So really powerful story about how to deploy technology in pretty dire circumstances to achieve an amazing outcome when we implement technology thoughtfully with motivated partners and focus on what does the patient need when and how can we deliver their needs in a way that gets the job done in terms of achieving a health outcome. So in this picture is actually our team, since we actually sent our team of designers, engineers, myself is hidden somewhere in this picture, to visit this home. at the end of this whole study, because we really believe in putting the person at the center of what we do and building technology that's responsive to people and not pushing technology into places where it may or may not have an impact. So let's backtrack to 2010, 2012. So this is the home. We had a home of cognitively impaired males, and we actually had 2 males die during this time of tuberculosis. Of course, this prompted an investigation from the health department. Lo and behold, we have many more cases of active TB up top, and we have a whole home of people who were exposed to tuberculosis. So tuberculosis, you can either have the active form, which means you're contagious, you really need that medication and support, otherwise you can potentially die or get very sick and lose weight and infect others. But for those of you who may have been around someone with active tuberculosis, it could have been on a bus or a train, or you may not have ever known. You may have been exposed to latent tuberculosis and you have it, but you're not symptomatic. You don't really need treatment unless you're high risk. And you can go your whole life not knowing. But because this home was very close quarters, all the air was being shared, it was a shared living facility, the health department said, you know, we need to investigate. We're going to make sure that everyone takes their medication. But something got lost in translation, and the policy implication of this is actually pretty interesting because the CDC requires that if you have active tuberculosis or if you're contagious, you do need to do directly observed therapy, make sure your patients cure so that infection doesn't spread. But in this bucket of people here that have latent TB, you can take that on your own. You can take your medication, go about your day, and people are fine with that. But the pill burden, thinking about this, if you have active TB, you could be dealing with 15, 20 pills a day for 6 to 24 months. If you have latent TB, it's a lower pill burden, but you still may have many different pills and you're self-administering. You don't know what you need to take or not. And throw in cognitive impairment, you don't know what you really need to be taking. So what ended up happening was there was an investigation. Everyone did the best they could. We had a document, medications were dispensed, and we thought, you know what? We contained the bulk of this outbreak. Everything is fine. Here we are in 2012. Let's move on and tackle TB in other parts of the island. But here comes 2016. One of those people who on paper, they were dispensed medication, they were given medication. So if they took their prophylaxis, they should not have activated their TB. But one of those patients from that original outbreak was genotypically linked to a 2016 outbreak. And now we have a whole new outbreak that started because somebody didn't take their medication the first time around. So this was during December 21st, I think was the actual date that we started. And it was really important because the medical director at the time, Dr. Dana Thomas, she literally had no resources. They tried live stream video. It couldn't work. It's the middle of the island. No one is going to have connectivity. They had one field worker to do the entire island on just the active TB cases they knew about, much less being able to active case find. So I actually shipped an old Android phone of my own to Dr. Thomas, who drove it up to this home and put it in the home. And the way the app works is even without any internet connectivity, you get reminders, you can still engage in the app, you have the medication, they'll tell you. And we had the healthcare worker who went up once a week, transmit those videos to review it in San Juan. And we actually ended up putting everybody on the emocha app to do their video DOT. Because typically, again, this bucket of people don't have supervised dosing because you're self-administered, but given the high-risk scenario, we wanted to make sure everyone had the tools to be successful. So even in this very challenging environment, we were able to get everyone up to about 92% adherence in the active TB group and 87% adherence on average, with a range for both in the latent TB group. And very importantly, we were able to quantify, and Henry Olano was the researcher who led the charge on quantifying this impact. We're able to tie clinical signs of improvement from the time that patients started using video DOT, notably weight gain, since One of the signs of tuberculosis is if you're very sick, you're not taking your medication, you lose weight. So we were able to see the changes in weight gain before and after implementing emocha, so everyone gained their weight back. And we were able to get 577 doses of medication observed. We saved 240 driving hours, and every single person completed their TB treatment. And here we are a few years later, and everyone is happy, healthy, and strong. And our team was able to go before Hurricane Maria hit to visit this home at the time. And it's a powerful story on why you really need to visit your end users for whatever space in healthcare or not even healthcare you're in. We designed technology to help community health workers, nurses, on-the-ground frontline staff. And it was really important to us when we took our team to Puerto Rico to shadow what a community health worker would do without our technology to visit this home. So Henry Olana, who wrote the publication, was actually a directly observed therapy worker himself before he moved on, and he's now actually going to Miami Med School. And he drove us to the route of this home, and there's one road that gets you to the top of the mountain. Turns out there's a down power line. We couldn't actually get up. We had to go around the whole base of the mountain and talk to how many people to do the back roads around the base of the mountain and circle up. And basically took like an hour and 15-minute detour to get to the home because of one down power line. And that problem is what any community health worker would have to do up to every single day for 24 months. So just to put into perspective, like why you build the things you build or why you're interested, I use that as an example on, wow, our engineers think about that when there's a bug that comes in or if there's something urgent and we say we need to drop everything and do it, there's a context for why that's so important, aside from a client said that it needed to be done. So quantifying this impact was really only possible because of CDC partners and the Puerto Rico Department of Health, and proves as a powerful story on, one, technology is a tool and can generate tremendous outcomes if we use it thoughtfully and in the right environments at the right time to solve the right problems. But this case study, and I brought actually some of the publications, so if you're curious, it's a one-pager on the table over there. But I wanted to highlight this because I think this has, the purpose of this meetup is to think about what does person-centered care mean, what does population health mean, and public health mean. And I think there's a lot of themes in this case study that can help generate thought into what this means for larger health systems, because we implemented a technology in a sector of healthcare that very few people know about and quantified this impact. And I like spending a lot of my career, and I'm very fortunate to work with amazing partners all over the world, really, to see how does this speak to larger themes and how can we help in TB and other diseases. So I wanted to get into a little bit of a discussion on public health and population health, and I have some of my own thoughts, but I was wondering if anyone wants to raise your hand and say the difference between the two, or the similarity. Kurt.
I think what when I hear public health, I think about it more in terms of centrally provided services that might address population health, but might also just address other forms of clinical care, whereas population health is in a way, in my mind, the person-centered term. There may or may not be public health working in population health, but you're going to have population health no matter what.
Thank you.
So is population health, is that more targeted to like specific populations or populations in general?
Possibly.
So the way I've heard population health uses the term is it's the population is defined by its relationship to a given entity. So I've heard it used a lot in terms of a specific hospital or healthcare system thinking about their own population health and understanding like the obligation that they have to provide care to this population.
Yeah, it's interesting. There's actually no fixed consensus on what either term is. So I tried to go in and see what is a commonly acceptable definition of these things and how has that changed since these definitions were made, because I think language has power, and there's a whole sector of research that shows how the language we use can impact what a prescriber might give a patient or how health behaviors are changed just from using, in like opioid use disorder, the word addict versus person with opioid use disorder, and the vast differences in treatment outcomes you get from either of those options. So what I found was the last formal definition of public health that was widely accepted was in 1988 by the Institute of Medicine. And it's defined as what we as society do to collectively to assure the conditions in which people can be healthy. So addressing those foundational issues. And there's a government responsibility in this as well. And population health, the very first definition came out in 2003, so not that long ago in the grand scheme of things, in this publication by Kinding and Stoddard out of the American Journal of Public Health. And they defined it as an opportunity for healthcare systems and agencies and organizations to work together in order to improve the health outcomes for the communities they serve. So I put these up there because I think it's interesting to think about how we're addressing public health in one way and population health in another way and how they feed into each other. And what I think is interesting is how that all relates to this larger body of Centers for Medicaid and Medicare Services. So most of this country's vulnerable population is served by an entity that has a lot of variability in how it's administered and how services get distributed and delivered essentially state to state. So we have these old definitions of very popular terms. I'm sure everyone's probably heard population health or public health or patient-centered care or person-centered health in the last couple of months, if not the last few years. And I think CMS is actually catching on to some of these broader themes of thinking through what people really need and how can health systems better serve people to improve public health in one capacity, but also speak to larger themes of tying entities to the communities that they serve. So does anyone know about the CMS, how CMS basically sets reimbursement rates and fee schedules every year?
What does CMS do?
Oh, the Centers for Medicaid and Medicare Services. So it's the all-knowing funding entity for every Medicaid and every Medicare beneficiary in this country. And Medicaid is basically the bucket of money for people who have lower resources and are under the age of 65, to oversimplify it. Medicare is meant for beneficiaries or people 65 and older who have a different set of needs. So two different sets of people, but they're housed under the same umbrella. And all of the legislative regulations, rules or guidelines that CMS, the Centers for Medicaid and Medicare, puts out has a ripple effect on how we deliver health services everywhere else, how products get built by private companies, how hospitals deliver care, how a provider who's in rural Mississippi delivers care compared to someone here in more urban Philadelphia. So for the first time this year, there's an administrator for CMS, so one person who's responsible for the agency's vision, mission, and every year CMS essentially puts out a list of services that are reimbursable. So if a provider sees a patient and the patient has a wound, there's a code for evaluating a wound care, any kind of niche service. But I think it's interesting what they set out in their vision early this year at the CMS Quality Conference. So Administrator Verma, who runs the Institute, set this vision with three main objectives. So everything now that CMS is doing is geared at empowering patients, focusing on results, and unleashing innovation as their kind of taglines for all the initiatives that are being fed. There's a widespread recognition that in the larger health system, much of what ails the system is attributed to flaws in reimbursements. So we're able to impact a lot and do so much in local health departments because you almost have this single payer system set up. The CDC cooperative agreements fund all local health departments to deliver these services, and we can implement technology to improve processes and quantify cost savings. And we have this little network. But what emocha has done in public health departments, we've been translating into Medicaid managed care settings. We work closely with federally qualified health centers, with private clinic networks, with academic medicine. And all of these stakeholders have such different interests in how underlying business models impact the decisions they have to make in terms of keeping a door open, adopting a new way to do business, essentially, or keeping in clothing because they get reimbursement in the door. So I think this is one of the first times that we've had a statement of what we're doing isn't working. Everyone wants to fix healthcare, but we can't keep knocking on the same door and doing the same things and expecting different results. And how many of you are, actually, I should have started with this. How many of you are in healthcare? How many of you are in product design? How many of you are in technology in some way, shape, or form and are just curious? Good, okay. Just out of curiosity, what industries are people from?
Retail.
Retail? Marketing tech? Something in between for everyone else? Cool. So I'll spend less time going into the nuances of healthcare, but just so you know, if you're outside of healthcare is a really complex environment. And if we can look at healthcare problems and learn from them and apply them to other industries, that's how we improve population health. Because there's a shift in thinking in terms of how we deploy interventions and technology. And I'm going to skip to this one statement of realigning incentives to pay for the results we desire to get to this idea of social determinants of health. So how many of you have heard that buzzword too? Lots of buzzwords in this presentation. All of you, if you're in retail, if you're in tech, if you're doing financial services, I think we finally have come to this tipping point in healthcare of realizing healthcare is not driven by medical systems necessarily, right? There's been really interesting work done looking at how do we put interventions in barbershops, because we know a lot of the people who go to barbershops in these urban areas have high blood pressure. How can we go there and engage patients and get them to have better health outcomes? So that was a big New England Journal study a few years ago now, just looking at designing interventions in new and creative ways. And with CMS now recognizing social determinants and understanding the role this plays in health, all of you guys who may not be directly linked into health are now part of that ecosystem, right? So from like an emocha perspective, we impact the medical needs of a patient. So every person is going to need to take medication. They need to be supported and guided. And that's our little slice of the pie. But what's interesting is for every patient that we have on our platform, we get a very cool insight to their life every single day. Whether they're in their home, they're in their lived environment, they're telling us about their day, they're showing us their medication and taking it back. But what's interesting is you learn about their life that way, much more beyond medication. So as a good example, we have an older 62-year-old woman who's on diabetes medication. We have in-house emocha adherence coaches, which are essentially personnel who watch the video on behalf of health systems who don't have that built-in capability to do it themselves. And all we knew about this patient was her A1C was through the roof and she needed help with medication. And that was the first thing that we knew about her. So of course we started her, she's submitting videos and she's showing herself taking the medication. And it turns out she can't take her evening dose on time because she's going to drive across town to pick up her granddaughter every day. And she doesn't have a way to do that in a car, so it takes her about 2.5 hours to go from point A to point B. She can't get to her appointments. She's not going to have the resources in her home to eat healthy and eat to her diet because she doesn't live in an area that has healthy fruits and vegetables or fresh fruit. So this idea of healthcare not being delivered solely by the medical community is emerging and becoming more and more clear in terms of integrating that into efforts within clearly the medical community, but having larger discussions of now we have some health insurance companies who are paying Dollar Generals to put fresh fruit in the Dollar General so that a patient can drive to their Dollar General and get fruit to make sure that they can eat healthy. So as I think through payment incentives and healthcare and this idea of patient and person-centered care, which is my next little thought exercise, I wanted to see how people define these two things. It's not a trick question, there's no right or wrong answer. Let me put that out there.
Sure.
Yeah.
Say that patient-centered care is under the construct of what we know about treating health, like the DSM or the by the book, and a person-centered healthcare is looking at it holistically. Got everything involving everything around it, how's the lifestyle.
Anyone else?
Yeah, patient-centered for me is more about defining their patient's interactions with the health system in some way, whereas the person is like everything else, the entire sum total of their experience.
Like the patient-centered approach is an objective approach, where the person-centered care is more subjective and humanistic.
I like it. Yeah, this one is also interesting because terms are emerging, and I think it's important to think critically about the language we use as it relates to healthcare. So the patient-centered care definition that I found was from the New England Journal, and it basically ties into this theme of patient-centered care is an individual's specific health needs and desired health outcomes are the driving force behind all healthcare decisions and quality measures. Patients are partners with their healthcare providers, and providers treat patients not only from a clinical perspective, but from an emotional, mental, spiritual, social, and financial perspective. So we're getting somewhere. This is good. And person-centered care is an even newer word that is not defining a person by the disease in which they have or the conditions in which they have, but it is based on seeing the person and not the medical condition, and acknowledging people's essential human dignity, treating people as individuals, and finding out what's important to them relative to their treatment and care. So our company is really design focused. So we have a team of designers who are out interviewing patients, providers, and understanding mechanics. And the more you talk to patients, or the more in your own field you talk to end users, if you talk to an end user, you're going to get a very different answer than someone who says that they talk to end users. And I want to get to this idea of recognizing what's important to people as it relates to designing and implementing technology that I think translates to other industries, using a different example of some of the work we do for opioid use disorder. So by way of background, we've been doing our work in tuberculosis and quantifying that impact for the last 5 years. And we've been really fortunate to work with amazing partners using the technology for opioid use disorder for patients who are new to medication-assisted treatment, for hepatitis C, for HIV, for chronic conditions like hypertension, diabetes. And for one of our studies, we had a clinician scientist, Dr. Judy Sweet at the University of Washington, just interview patients who were diagnosed with opioid use disorder on why do you forget, what are your struggles with adherence? Do you have struggles with adherence? And thinking about a very basic question to start asking before you get so deep in the weeds of designing a product or solution for a problem that you think you know, but a patient doesn't recognize as meaningful for their own experience. Because we know that just because someone has a disease doesn't mean that they recognize that disease as really impacting their life. So it goes into the difference of a patient versus a person. And I like this patient quote on a barrier for adherence, is the background of this, is forgetfulness. You get busy doing things, or definitely if I'm screwing up and getting intoxicated or drinking or whatever, like when my friend just came to town. So that's just what always happens when we're together. We get busy talking all day, catching up with everything. I haven't seen him for a long time. So then I just be like, did I take my evening dose? Then you talk to the provider and see what the provider says about the same question. So, is adherence a problem? Do you recognize adherence as a problem? I think a lot of our patients are in communities of people who are in various stages of use or recovery, and also communities that have a strong ethic of mutual support. They want to help each other. What we consider diversion, and for those of you not in medicine, diversion is, I'm a patient, I have opioid use disorder. I was prescribed medication for my opioid use disorder the same way a patient with diabetes would get diabetes medication. But I'm going to cut that dose in half and sell some on the black market on the street because someone else is going to benefit from it, and they may not have healthcare, and they might not have a doctor. So that's what diversion is, like giving medication to someone else who wasn't prescribed. So what we consider diversion, which is looked at as like a bad thing in healthcare, they consider helping their friends or their spouses or their family. So challenges like, it's hard for me to have bus fare, we hear more than, oh, I needed to give half my medication to my friend. We never hear about that because people are aware that the consequence for that is very serious. So for patients, when we started talking to them, we realized they have forgetfulness just like everyone else. How many people in this room have ever forgotten to take their medication when they knew they were supposed to? Me. Yeah, pretty much everyone. And for providers, a lot of providers think they have so many other things that are going on in their life, they probably don't even need to take their medication, or they clearly know that that's important because the provider was thinking that the patient had a different problem. So I use this just as a juxtaposition on if we want to design solutions for people, it's really important to talk to that end user just to see what they have to say. And as a next question, we asked more specifically, what does emocha or video DOT, what does it sound like to you? Because we want to know. Again, most people in this room probably thought I was a Looney Tune when I said people video record themselves taking medication, right? So we want to know. And turns out when we asked a patient, I think a lot of it, the Suboxone, and Suboxone is the name of the drug that people use for their opioid use disorder, the brand name, in general relies on a lot of trust and communication between the patient and provider or providers, So I think video DOT would be good. Everybody could be on the same page. They feel good about it, especially when you're changing doses or maybe had problems in the past staying in the program. I think it would help hold people accountable. So when we started talking to providers again, providers thought, nobody would ever do this. This is ridiculous. But it turns out it had a value to a patient. And you only quantify those values if you put yourselves in the position to hear from your end user specifically and design solutions around that and respond to feedback for those of you that are engaged in designing platforms to solve problems. So with that, I wanted to have this be a more open discussion with kind of leading in food for thought.